So I would like to very quickly welcome our speakers. Can we go to the next slide? Yes, so I'd like to welcome Professor Solomon Kadiri, who is a nephrologist of the University of Ibadan, University College Hospital, Ibadan. He is the past head of medicine, I beg your pardon, at the University of Ibadan, and he's the past president of the Nigerian Association of Nephrology. He's currently a fellow of both the Nigerian Association of Nephrology and the International Society of Hypertension. Professor Kadiri has his interests include epidemiology of hypertension and the interactions between the kidney and hypertension. Professor Kadiri has participated in local and international studies. He is a former member of the African Region Group of International Society of Hypertension. He has participated in training sessions and lectures on hypertension. He has also supervised many fellow dissertations. He was also involved in drawing up guidelines for the International Society of Hypertension / WHO, and also served as the chairman of both the Guidelines Committee of the Nigerian Hypertension Society and the Nigerian Association of Nephrology. Please, a round of applause for Professor Kadiri. You can put a thumbs up in the chat or put a clap on your profile for Professor Kadiri. We'll also like to very quickly introduce Professor Brian Rayner, who is an emeritus professor and senior scholar of the University of Cape Town. He's the past head of the Division of Nephrology and Hypertension at the Goethe-Spohr, please forgive me if I'm murdering the names, but Goethe-Spohr Hospital and University of Cape Town, and established the Kidney and Hypertension Research Units in 2016. He's a past president of the Southern African Hypertension Society, so he has extensive experience in this particular sector. He also received the World Hypertension League Award for notable achievement in hypertension in 2014. He has active research interests in therapy of hypertension, mutations in the ENAC, genetic determinants of salt sensitivity, primary aldosteronism, and assessing adherence in hypertensive patients. He, together with Professor Sidat and Veriava, he wrote the 2014 South African Hypertension Practice Guideline, and he has 165 publications in peer-reviewed journals. He has made over 120 presentations at local and international congresses and has written 6 chapters in books. So we have pulled in the best. They have graciously accepted this invitation to come and share their knowledge from their wealth of knowledge and their wealth of expertise. So please, a round of applause for both Professor Solomon Kadiri and Professor Brian Rayner. Please put a round of applause, give a round of applause, and appreciate their efforts to be here. So the first voice you would hear for part 1 is Professor Kadiri, who will begin, and then immediately after him would be Professor Rayner. Over to you, Professor Kadiri. Can you hear us?
Yes, thank you, Adara.
Thank you so much.
Who's got control of the slides?
So we have our DJ, our slide DJ.
Oh,
behind
okay.
the
All
slide.
right.
So
Okay.
We'll follow you as you go on. Please let us know what you like us to do.
Okay, first I would like to thank mDoc for inviting me to this lecture. And I say good afternoon to everyone. I think it's the afternoon everywhere. On the African continent about this time. Next, the title of the lecture is Hypertension in Diabetes, and this will be given in about 15 minutes or just under epidemiology and pathophysiology. Next slide, please. Next slide, please. Yes, this is the outline. We'll just spend a few seconds talking about definitions, then diagnostic criteria for hypertension and diabetes, epidemiology, then pathophysiology. Just a few words on each of these. Next slide, please. Now, by way of diagnosis, random plasma glucose over 11 millimoles per liter, or fasting plasma glucose more than 7 millimoles per liter, or if we're using whole blood, then fasting blood glucose of over 6.1, then 2-hour PP, 2-hour postprandial plasma glucose of over 11 millimoles per liter. And we might also add that the WHO also accepts glycated hemoglobin of more than 6.5% as being representative or indicative of diabetes. So we have to be certain about this, and these results have to be repeated, not just once. It's not enough to get a single value and label the patient as being diabetic. This has to be repeated. And with hypertension, the office reading has to be above 140/90. I think for most part of the world, that's what's currently agreed. There are moves to drop the cutoff point to much lower than this, but for now, I think 140/90 is what is generally accepted. But we must also note that the cutoff point for hypertension differs whether one is in the clinic or in the office, or whether the patient is at home, or whether this is taken at night or during the day. So the time at which the blood pressure is taken matters a great deal, and the site, whether in the office or at home, matters also. And from this table, we can see the various cutoff points. So a patient who's consistently at home gets his blood pressure at about 130/88, 135/88 is likely to be hypertensive. Next slide, please. Global diabetes. This slide talks about or addresses the prevalence of diabetes and comorbid conditions in various parts of the world. Prevalence of diabetes worldwide is put at about 9.3%, and that gives about 463 to 500 million people who are living with diabetes in the world. The prevalence is a bit higher in the urban areas than in the rural areas. We have about 10.8 to 7.2. The prevalence is also higher in high-income countries than in low-income countries, more than double the prevalence. Then 50% of persons living with diabetes are not aware of the condition. In other words, they are likely to be discovered only when routine testing is done. In other words, they're asymptomatic, they're not aware at all. Nephropathy, kidney disease in diabetes, is very common, and that occurs in about 30 to 50%. And it's the commonest cause. Kidney disease, diabetes, diabetic nephropathy is the commonest cause of chronic kidney disease worldwide. If that mightn't be the case in Africa, glomerulonephritis, hypertension tend to be commoner, but diabetes is fast becoming a very common cause of chronic kidney disease, and that is of very importance. Next slide, please. With regard to hypertension, the prevalence in the world, worldwide figures range this from WHO, about 26% to 29%, maybe 30%. In Nigeria, it's about 30 to 35%. And we have similar figures from some African countries. But in some other countries, the prevalence rate will be much, much lower. Hence, we have the world prevalence of 26, which is lower than the 30 to 35%, which we tend to have in Nigeria these days. If you look, if in the literature, you might find some figures going up to 40%. But those really have been based on rather small studies, and the larger studies tend to support this 30 to 35%. In diabetes, the prevalence, particularly type 2 diabetes, in type 2 diabetes, the prevalence of hypertension is about 80%. In other words, when patients are diagnosed with type 2 diabetes, they are likely to already have become hypertensive. So the prevalence of hypertension is more than twice the rate of hypertension in other conditions. The prevalence of hypertension in diabetes is more than twice the rate in other conditions. In other words, there's a very close association between diabetes and hypertension. Hypertension, just like diabetes, would increase the risk of cardiovascular disease and chronic kidney disease. Next slide, please. This slide from the UK prospective diabetes studies just shows that with increasing blood pressure, the risk, the hazard ratio for microvascular complications and for macrovascular complication, one of which is myocardial infarction, do increase. As the blood pressure goes up in diabetes, the risk of developing microvascular complications, retinopathy, eventually some microvascular complications result in nephropathy, and then the macrovascular ones, large vessel disease, myocardial infarction, do go. So it's a very important slide. It's important to note that hypertension, diabetes, particularly when they occur, portend very, very severe consequences if not well managed. Next slide, please. Now, issues with BP measurement in diabetes, will just pay a little attention to these terms. Pseudo-hypertension refers to a situation in which high blood pressures are obtained when an indirect means of measuring blood pressure, indirect like the auscultatory, the cough auscultatory measurement, is used. But when intra-arterial measures are taken, the blood pressure is normal. And clinically, this manifests with high levels of blood pressure, but very little end organ damage, which just implies that the high levels of blood pressure we're obtaining are not really related to increase in blood pressure. Pseudohypertension invariably results from the hardening of the arteries. So you need a lot of pressure to constrict the arteries, whereas the pressure rather inside the veins, inside the vessels, is not that high. So that's pseudohypertension. It's quite common in hypertension, and practitioners should be quite aware of its occurrence. Obesity, again, very common, particularly with type 2 diabetes. And with obesity, it's quite important to get a suitable cuff, a cuff big enough to be used in an obese individual. If you use a cuff to measure blood pressure that is too small for the arm, you get a falsely elevated reading. And since obesity is quite common in type 2 diabetes, it's important to note that it's important to get a proper sized cuff. Then masked hypertension refers to a situation in which the blood pressure is high. Sorry, the blood pressure outside the clinic is high, but when the patient is in the clinic, the blood pressure tends to be normal. Again, this is common in diabetes and some other conditions, common also with large intakes of alcohol. So it should be noted. So in a diabetic, it's important that when blood pressures are taken, consideration is given to office blood pressure and the kind of blood pressure the patient notices at home. Autonomic dysfunction is quite common in diabetes, and this could give rise to orthostatic faults in blood pressure. The implication of this is that when you're measuring blood pressure in diabetic, it's also important to take the blood pressure in various positions, lest you miss a case of orthostatic hypotension, in which case the patient may have seemingly normal blood pressure when he's seated, but when he stands, the blood pressure falls very, very markedly, and some patients actually become symptomatic. So if care is not taken, that could be missed, and this is quite common in diabetes. These 4 conditions are common in diabetes, and when practitioners are dealing with diabetics, they should have them in mind. Next slide, please. Now, paths to hypertension. The title of the lecture is Hypertension in Diabetes. Paths to hypertension. How does a diabetic patient become hypertensive? Or in what ways are diabetes and hypertension related in individuals? One, the hypertension could be totally coexistent, not related to the diabetes. We must always note that. In type 1 diabetes, the hypertension typically follows chronic kidney disease. Hypertension is not an integral part of type 1 diabetes, and hypertension tends to occur when chronic kidney disease has supervened. And type 1 diabetes is usually a disease of the younger people. So hypertension takes a while to appear, to manifest. In type 2 diabetes, as we just mentioned, hypertension is quite common. Type 2 diabetes tends to go with insulin resistance, insulin deficiency, insulin resistance. And this is usually in the elderly. It is also associated with chronic kidney disease, of course, but the hypertension tends to occur long before. And as I mentioned earlier, even at diagnosis, a good number of type 2 diabetics already have hypertension. Then the metabolic syndrome, which consists of central obesity, insulin resistance, hypertension, hyperlipidemia, hyperuricemia, often leads to diabetes mellitus. In other words, with time, glucose intolerance and impairment may ensue, in which case patients with metabolic syndrome actually can develop type 2 diabetes mellitus. So these are the various ways in which hypertension may occur with diabetes. Next slide, please. Now, hypertension and chronic kidney disease. As we mentioned, hypertension leads to chronic kidney disease, diabetes leads to chronic kidney disease. And when they occur together, we can imagine that progression to kidney disease will be much faster and will be more severe. Hypertension is the cause of end-stage renal disease in at least 25% of people worldwide. It is the leading cause of end-stage renal disease in Blacks, particularly in the United States. May not be the case in Africa, but in the United States is the leading cause of end-stage renal disease. And in whites is the second leading cause following diabetes. Next slide, please. Now, not everyone who is hypertensive develops chronic kidney disease. And it's been shown that some variants of APOL1 polymorphisms, and we won't go into much detail about this, are prone to developing kidney disease. This applies to hypertension, it applies to diabetes, it also applies to focal segmental glomerulosclerosis. APOL1 gene polymorphisms, common in Black people, has been associated with the onset, with the progression to kidney disease in hypertension, diabetes, and indeed in some primary forms of glomerulonephritis. Next slide, please. Now, hypertension causes target organ damage even before symptoms appear. And following that, symptoms may then appear. Symptoms of heart failure, stroke, cognitive dysfunction, renal failure. These are all symptoms. And these occur long after the target organ damage. The target organ damage may not be noticed unless the patient is investigated. So let's not wait for the symptoms to appear before we institute care. Target organ damage should be looked for early in the course of managing patients with hypertension and indeed diabetes. Next slide, please. This traces the origin or the progression to nephrosclerosis to chronic kidney disease in hypertension. I'll just summarize, I just simplify it. There could be glomerular ischemia or glomerular hypertension in the course of hypertension. Glomerular hypertension tends to occur a lot more in Black patients than in white people. Glomerular ischemia, some people believe, tends to occur a lot more in white patients. But whichever, either glomerular ischemia or glomerular hypertension, glomerulosclerosis will be the end result if that process is left unchecked. Next slide, please. This reiterates what I have just said, but this focuses a lot more on glomerular hypertension. It's basically similar to what I have just said. Next slide, please. This describes those slides described in words. In the case of glomerular ischemia, there's a breakdown of elastic fibers in the arterioles. This is replaced by hyalinosis. There's intimal thickening, endothelial damage, and then ischemic glomerular results. There is genetic heterogeneity. In other words, not all patients who have hypertension will suffer from this. Some will suffer from this to greater extent than others. Next slide, please. Now, in the case of glomerular hypertrophy, which, as I mentioned earlier, tend to be commoner in Black people, there is loss of autoregulation in the afferent arterioles, such that the pressure, the high systemic pressure is transmitted directly into the glomerulus, resulting in increased glomerular pressures, which leads to hyperfiltration, glomerular hypertrophy, glomerulosclerosis. And this is much commoner in Blacks than in whites. Next slide, please. Now, this slide describes the cause of kidney disease in diabetes. In the early stages, microalbuminuria appearing, That's the red, the brown red line denotes microalbuminuria, and then the blue one traces the glomerular filtration rate. The GFR is normal, microalbuminuria is just appearing. In the later stage, the patients tend to develop hyperfiltration in diabetes. Microalbuminuria is worsening. The glomerular filtration rate goes up to some 160, 170, 180 sometimes, the GFR. That stage, nephropathy is coming on. Then as the disease progresses, the albuminuria increases, gets to very high levels. And at that stage, the GFR has begun to drop markedly. We also note that much later, the proteinuria drops. That does not necessarily imply that the patient is getting better. No, with worsening of the GFR, filtration even of protein drops, and so the proteinuria itself drops. Next slide, please. Now, the mechanism of hypertension ensuing in type 2 diabetics, I alluded to this earlier when I was talking about type 1, type 2. In type 2 diabetes, obesity is quite common, insulin resistance and hyperleptinemia, sympathetic activation, and also activation of the renin-angiotensin system. These are associated with insulin resistance, and that's thought to be one of the ways in which hypertension ensues. There are also other products, glycated end products. They also are injurious to the afferent arterioles, and this can also much later result in elevation of blood pressure. So of importance here is to note that sympathetic activation and activation of angiotensin renin system are quite important in the onset of hypertension in type 2 diabetics. Next slide, please. This slide, again, addresses the previous one, and they talk about similar things. So I think we can just go on to the very next one. But my time is nearly up now. Next slide, please. This is a diagram of a glomerulus. This here is the afferent arteriole. This one is the efferent arteriole. The usefulness of this will come in later when Dr. Rayner talks about the treatment in diabetes. The high pressure, systemic blood pressure, when there's failure of autoregulation here, the high pressure here transmitted directly into the glomerulus, leading to high pressure in the glomeruli and hyperfiltration. Hyperfiltration is injurious to the mesangium, injurious to the tubules, and that marks the beginning of glomerulosclerosis and the kidney disease that is seen in hypertension, and also in another manner, the kidney disease that is seen in diabetes. Next slide, please. And this is the last slide, and just shows histology sections. There's not much to be explained here. Just shows that this is the normal segment of a glomerulus, the segment of normal glomerulus, and this one, B, shows one form of diabetic kidney disease, diffuse glomerulosclerosis. And this one here, C and D, show other forms of diabetic kidney disease, nodular glomerulosclerosis. Just for interest, those who might want to know how diabetes affects the kidneys. And I think, thank you very much. I've exceeded my time, but thanks a lot. That's the last slide. Thank you.
Thank you so much, sir. Thank you so much for also managing your time. Truly, truly appreciate it. So we would hand over very quickly to Professor Rayner. Hello, sir. Can you hear us?
Yes, I can hear you. Okay,
wonderful. Over to you, sir.
Good afternoon, everyone. And thank you for the organizers for inviting me to this very special session on treating hypertension diabetes. My focus will mainly be on type 2 diabetes, but the same applies to type 1 diabetes as well, except that generally hypertension comes when they develop chronic kidney disease, as outlined by Professor Kadiri. Next slide, please. I think it's also important in medicine that if you don't have data, you're just another person with opinion. So really look at the data, and hopefully I'll present data that could convince you how to treat hypertension and type 2 diabetes. Next slide, please. Now, as we heard that the prevalence of hypertension in diabetes, and from this survey done in the Canary Islands, was 80%, and that's very similar all over the world. And if you have impaired glucose tolerance test, it's 60%. So there's a period of metabolic syndrome going on to diabetes, and hypertension becomes a dominant player. Next slide, please. Now, it's really important when you look at diabetes, it's a multi-system disorders with hyperlipidemia, hyperglycemia, and hypertension. But the dominant thing that prevents cardiovascular outcomes is the lowering of blood pressure, as shown here. For only 4 millimeters lowering of systolic blood pressure, you reduce events by about 12%. So it's important to recognize how important hypertension is to protecting against heart disease, but it's also really important in protecting against microvascular disease, particularly in the kidney. Next slide, please. Now, Professor Kadiri has emphasized the importance of taking blood pressure. It must be done correctly to diagnose the condition. It can be made on a single measurement of greater than 180, 110, but you need repetitive methods to confirm it. Ideally, I know some of you are from rural areas, to confirm it with out-of-office blood pressure as outlined by Dr. Kadiri. And also remember the standing position, because many diabetics after long-standing diabetes have postural hypertension, and treating the hypertension can result in significant symptoms. Next slide, please. Now, when you evaluate a patient with hypertension and diabetes, you must go into the medical history, measure their blood pressure, risk factors, comorbidities like stroke and heart failure and so on, kidney disease. You must do a physical examination to examine the heart and circulation and other systems. And the essential blood tests that you need to do are sodium, potassium, creatinine with a calculation of EGFR, a dipstick urine, and ideally you should do fasting lipids for hyperlipidemia, fasting glucose, you can do that on a glucometer, and ideally HbA1c, which gives you an idea of long-term control. You also need to ideally look at the fundi. That can be very difficult, may not be available for you because one of the complications is retinopathy. You also ideally should do a urine albumin creatinine ratio, which gives you an idea of the presence of kidney disease with EGFR, and I'll come back to that. ECG is also ideal to detect ischemic heart disease, hypertrophy of the ventricle, and atrial fibrillation are common complications. Remember, angina or ischemic heart disease can be silent in diabetics, so it's important to do that test. Next slide, please. Next slide, please. And just remember, if you look at the slide, at all levels of blood pressure, given what I've told you, diabetics in the last row, they're at high risk. And if their blood pressure is above 160, 100, they are at extremely high risk. So it's important to remember this, how vulnerable these patients are and how you must treat them diligently. Next slide, please. Now, regarding chronic kidney disease, I think it's going to be important to evaluate this because it's a really important complication of diabetics, as outlined, occurring up to 40% of people. You need to take a combination on the left-hand side of the EGFR from your creatinine, calculate the EGFR, and then calculate the albumin creatinine ratio, which the figures are given there, from less than 30 milligrams less than 3 milligrams per millimole, 3 to 30 milligrams per millimole, and greater than 30 milligrams per millimole. There are different units, but if you don't have access to that, a dipstick can be very helpful. If you've got persistent proteinuria in your urine, you've got diabetic kidney disease. So the trace, you've probably got what's previously called microalbuminuria, or small amounts of protein, and if it's negative, you don't have it. So, and everything in red means a high-risk patient and should ideally be referred to a specialist or a nephrologist for further management. They're high risk for deaths from cardiovascular disease and progression to end-stage kidney disease which is becoming one of the most important causes of end-stage kidney disease in the world. Next slide, please. And just remember, every patient must have lifestyle interventions. And just to show you on the right-hand column, if you've got early diabetic kidney disease, and you can see on the right, the increase in the pink. I wish I had a pointer in the pink. How important, if you smoke, or you're lazy, you drink excessively, and you're obese, how this increases your risk of getting diabetic kidney disease and other complications. But it's absolutely important these patients have lifestyle intervention, and I think you all know about it. Salt reduction, stop smoking, no excessive drinking, and activity. Next slide, please. Now, when you come to treatment, once you've decided, you go to the right-hand side. If the blood pressure is above 160/100, it's optimal to start drug treatment. It's essential these patients are at high risk. You must start drug treatment. I'll tell you what treatment. If you're on the left-hand side, now this is from the ISH, we looked at optimal and essential. Under optimal conditions, you should treat all. But unfortunately, many places don't have access and resources to do that. So it's essential. You can monitor these patients, particularly if they're low risk, if you go down. But diabetes makes them high risk. And it's important that these patients get treated with stage 1 hypertension. And that's defined by greater than 140/90. So they all need treatment. Next slide, please. And the treatment, ideally, from all guidelines now, is a RAS blocker, ACE inhibitor, ALB, CCB, in particular amlodipine, and a thiazide or thiazide-like diuretic. Some people prefer the thiazide-like diuretics like indapamide, but that's your frontline treatment. No beta blockers and other agents not recommended. Next slide, please. Now, what's your choice of treatment? The choice of step 1. If your blood pressure elevated, you start 2 drugs. You don't start 1 drug. And the 2 drugs you take is either ACE inhibitor or angiotensin receptor blocker with a calcium channel blocker in routine doses, particularly in a single pill, which includes compliance. If you don't achieve target, and I'll talk about target just now, you increase the doses to full doses. And then step 3 is to add the diuretic, indapamide or hydrochlorothiazide, what is available to you. And step 4 is add spironolactone and low dose if you've got resistant hypertension. Just remember, the most common cause of resistant hypertension is people not taking their blood pressure pills. So next slide, please. However, in patients from African descent, we have a different type of pathophysiology of hypertension. It's much more salt sensitive. And so they respond to slightly differently to people from the rest of the world. Next slide, please. So the International Society of Hypertension recommends people of African descent must be screened annually. They must undergo lifestyle modification. But here's a difference. You can do the CCB plus, and they say ALB because of the chance of angioedema with ACE inhibitors, or CCB plus a diuretic like indapamide or hydrochlorothiazide combination. So that is slightly different. You have a different type of choice. Okay. Next slide, please. Next slide, please. However, we must remember international studies showing that perhaps ACE inhibitors have a better track record in preventing cardiovascular events than ALBs. So that may influence your choice, which one you choose between, because you can't use both. You've got to use one or the other. So that's an important consideration. There may be better benefits with an ACE inhibitor. Okay, shown here in this diagram. I wish I had a pointer and I could illustrate it to you. Next slide, please. And also beware of beta blockers. In fact, in one of the intensive controlled study called ACCORD, use of beta blockers increase the risk of severe hyperglycemia and death from cardiovascular disease from hyperglycemia. So that's an important consideration. Next slide, please. Now, what is your target? Every diabetic must have their blood pressure controlled under 140/90. What the exact target is open to controversy. The Americans say less than 130/80 on the right-hand side. The Europeans say less than 130 for younger diabetics, 18 to 65, but not below 120. But if you're older, 65 or older, you go to 130 to 139. And that's what the WHO recommends and the International Society of Hypertension. Target most diabetics to between 130 and 140 systolic. No one really knows the true diastolic blood pressure that should be for diabetics, but definitely less than 90. Next slide, please. Now, the importance of blood pressure control here is that this is a study where they looked at blood pressure 154 from 140 versus 144. This is an old study, but a seminal study. Any diabetes endpoint was reduced by 24%, deaths by 32%, stroke by 44%, microvascular disease by 37%, retinal disease by 35%, and heart failure by a staggering 56%, just showing how important controlling blood pressure is. Next slide, please. Now, people thought maybe we should go much lower, and they did this intensive blood pressure control type 2 diabetes called the CORD study, also a seminal study. Next slide, please. So they really pushed the blood pressure right down to below 120 and between 130 and 140 for the control group. And then they looked at the outcomes, and people anticipated that there would be major benefits for lowering blood pressure to this degree. Next slide, please. And what happened is that the benefits were very small. A slight reduction in stroke, mortality, cardiovascular death, non-fatal MI were not improved by the study. So this was a surprise and a rethink, and that's why we went up to 130, 140 for target blood pressure, systolic blood pressure. Next slide, please. And this came with an adverse events, more hypertension, more bradyarrhythmias, more hyperkalemia, more reduction in EGFR, but not dialysis. So there was some harms coming from this low blood pressure. So I think in our type of practice, particularly in Africa, we aim for 130 to 140. Obviously, it goes to below 130 and patients keep feeling completely well. You can leave it at that level, but not below 120. Next slide, please. So, I mean, this summarizes that they've even done high quality 0.4, high quality controlled randomized studies where they looked at all the studies and they found the best fit was for less than between 130 and 140. But we need more randomized studies in this area. Next slide, please. But overall, if you want to get the best benefit, was in this study called the STENA-2 done in Denmark, where they looked at good control of diabetes, control of cholesterol statins, control of blood pressure, use of aspirin. And you can see in the intensive group, they got a 46% reduction in deaths, a 59% reduction in cardiovascular events. So just blood pressure is critically important, but you must focus on lifestyle, lipids, HbA1c as well. Next slide, please. Now, there's a new drug on the market that is very useful in diabetes, which is giving us really important results. It's becoming available in South Africa. I don't know if it's available by you, but it's good, particularly for diabetics who are at high risk, particularly if they've got chronic kidney disease and hypertension. Because these drugs work on the kidney by reducing sodium and glucose reabsorption in the proximal tubule. They lower blood pressure, they reduce weight, they're metabolically neutral, they decrease uric acid, there's less high potassium, lower HbA1c, and they prevent cardiovascular and renal events. Surprisingly, not stroke. That's perhaps one of the questions that came up. So really important. And just to show you what happens, next slide, in a study where they did in hypertension in African patients, and in red, the empagliflozin, the SGLT inhibitor, lowered blood pressure very significantly. I don't think it's given enough attention in Black patients, because we know they're salt sensitive, and this drug reduces sodium reabsorption in the kidney. Next slide, please. But also importantly, studies were done in chronic kidney disease where patients had GFR from 30 to 90 with varying levels of urinary albumin-creatinine ratios we discussed, and they had to be on ACE inhibitor ALB, which is a standard of care for patients with diabetic kidney disease. I perhaps didn't mention that earlier. So if you've got diabetic kidney disease, you must use ACE inhibitor or ALB. And they looked at the endpoints of end-stage kidney disease, serum creatinine, renal cardiovascular death, heart failure, cardiovascular events, all-cause mortality. Next slide, please. And quite clearly, you can see here, there was a 30% reduction in the primary endpoint, 40% reduction in doubling of serum creatinine, 32% reduction in end-stage kidney disease, a 22% reduction in cardiovascular death, a 28% reduction in introduction of dialysis, kidney transplantation, or renal death, and also prevented cardiovascular death. And this has been replicated now in 2 other studies, DAPA-CKD and EMPA-Kidney, and they went even to a low GFR of 20 mils per minute. But to note, most benefits were those who had A2 and A3, more albuminuria protein in the urine. So those with DIP6 positive were the ones that benefit most. Next slide, please. So the current recommendations for patients with CKD from Tele-ECHO is all patients must have lifestyle intervention, lipid, blood pressure control, exercise, nutrition, stop smoking, and glycemic control, but not too intense. You must get it below 8. You mustn't go below 6.5, otherwise you increase risk of hyperglycemia. Most patients should get SGLT2 inhibitors and RAS blockers, ALB or ACE inhibitors, unless there's contraindications. And some patients may need aspirin. We've moved away from aspirin in patients with hypertension, CKD, because the evidence is not there. It hasn't shown overall benefit. Reduce MI, but you increase hemorrhagic stroke and bleeding from the gastrointestinal system. So my last slide. Next slide, please. So controlling blood pressure in type 2 diabetes presents many challenges, and it's critically important. Target blood pressure is controversial, but I think now the consensus is between 130 and 140 systolic. Americans recommend 130, less than 130, 180. But if a patient goes to that level and is feeling well and there are no problems, I would leave them there. ACE inhibitors, ALBs with CCB and thiazide-like diuretic are the preferred frontline treatment. And in African patients, you can consider CCB and thiazide first line. Beta blockers are not generally advised, particularly if you're going for intense targets. However, you must use drugs that are available in your area. I know some drug availability may be a problem, so it's better to control the blood pressure with what you have in the clinic. And you must have a multifaceted approach to address all risk factors. And now the new kid on the block, the sodium glucose transport inhibitor, conclusively shown benefit for patients with diabetic kidney disease. Thank you very much for your attention.
Thank you so much, Professor Rayner. Thank you so much, Professor Kadiri. So we will just take a few questions before we jump very quickly into the case presentation. I have one question here. The participant is asking, the AHA guidelines for hypertension, which is 120/80 millimeter mercury, are quite different from those used by the WHO and Nigeria. Should we focus on elevated blood pressure when counseling patients or members in the case of those providing?
I think, look, the AHA-ACC is a very outlier in the treatment of hypertension. They define hypertension less than 130/80. It is just really not possible to even consider this in Africa, where 91% of people with hypertension are not controlled due to not knowing they have hypertension, they're not screened, they're not treated properly, and so on. So we need to focus on 140/90, and that's where the greatest benefit is. get down below 140/90 and start treatment pharmacologically above 140/90. If the patient is borderline, lifestyle is really important. Reduce the salt consumption. I mean, in Nigeria, they're having quite an emphasis on reducing dietary salt, which can reduce the blood pressure by 5 millimeters of mercury. Already you lower cardiovascular risk by 15% if you do that. So it's really important that, and I think the Americans are outlier, and there's no evidence to support this. They base their evidence on the SPRINT study, which excluded diabetics. So it's really strange to understand why they came to that conclusion.
Thank you so much, sir.